Welcome to the LowCarbMD podcast. No one is beyond help. No one is beyond hope.
As we have always said, we are bringing you medical information and cutting-edge science, but none of this is medical advice. Please seek out input from your own doctor.
Hello and welcome to the Low Carb MD podcast. Tro, we got a cool guy here today.
Yeah, another great doctor.
We got some history with and everything.
Yeah, out in Ohio, out in Indiana, doing really great work. This is going to be a good one.
Are you doing the intro, Tro?
No, go ahead.
Dr. Paul Kolodzik. I know I'm gonna butcher your name, man. I'm so terrible with names. But welcome,
Perfect.
Doc.
That was perfect.
All right, man. I figured you would have a little different accent. We just call you Paul. If we could do that again on the podcast,
That's fine.
we'll do that.
That's absolutely fine.
So, Paul, welcome. Tell everyone your story. Tell them, just go all the way back to your influences to go into medicine and what you saw in the system and how you ended up where you are now doing this crazy low carb stuff.
Okay, thanks. I've had a little bit of professional ADD, kind of moving from one area to another over 25 or so years. But first I wanted to tell you guys, it's a pleasure and an honor to be here with you. I'm going to put a plug in here. I might get you in trouble in terms of more phone calls, but I initially called you guys up about a year or so, just, Joe Schmo Doc out in the Midwest looking for some insight and some advice. And you guys were both so gracious in offering me insights into what you were doing and really how to help people. And I'm just appreciative of that. So I wanted to first thank you for that. And, as we talked previously, I initially was kind of tuned into your practices on the East Coast and West Coast and not as quite tuned into the podcast. So 3 or 4 months ago, I felt, I needed to really understand what this podcast is about. So I started listening to it. And I probably got about, 30% of your podcasts in now. But holy moly, I mean, you guys have so many smart people on here with so many great insights, and it's been an education for me. So I wanted to just thank you for doing what you're doing, and I look forward to listening to the rest of those.
No, thank you, man. Thanks.
Well, first of all, it's right up your alley. We talked about addiction medicine. I know you've been very involved in addiction medicine. I know you're also involved in emergency medicine. We know you have your MBA. I mean, you're a very accomplished doctor, and also outside of the system, right? You've been in the system and outside the system. So
Yeah.
We know the story. Brian and I know the story.
Right.
Share it with us, but I want the listener to kind of understand, how you got started, and then all the way up through, how you started to get out.
Okay, we'll give you a little background there. So first, as Brian and I were just talking, I did undergrad at the University of Notre Dame, so a little bit of rivalry with USC there in terms of football. And then I went to medical school at Wright State University in Dayton, graduated there as chief resident, and then did a fellowship for a year, which was an administrative emergency medicine fellowship. And basically that was to learn about the business of medicine in the context of emergency medicine, how groups were formed, how they did business. And if your listeners are not familiar, the way that usually works is a physician group in most of the country. Some places the hospitals employ the physicians, but the majority of places the hospitals contract with a group of emergency physicians to provide staffing services and medical direction to the emergency department. And the Wright State residency, actually, you rotated through 5 different hospitals, so you got to see how all these different emergency medicine groups worked. And then I went on, as you mentioned, Tro, to get an MBA. And so now I've been board certified in emergency medicine for about 25 years, went on to get addiction medicine boards about 5 years ago. You could grandfather into that. So basically lived most of my life in emergency medicine early on, and then graduated into an addiction medicine individualized private practice as well. And now I've added metabolic services to that. But can I tell you a little bit about the kind of the business side of my early career?
Yeah, absolutely.
Okay.
We know a little bit about it, but let's get the listener. I know Brian and I know about it, but let's get the listeners in because this is important. They don't teach us doctors how to run businesses.
The worst business people in the world are doctors. I'll tell you that. I could tell you that from experience for sure.
Yeah, it's like, how do you get experience? It's like you make decisions and, you make bad decisions, and that's how you get experience and then get good at things. So, you learn by doing. So when I got out of residency, I actually worked with a handful of other guys, and we started an emergency medicine group, had a couple contracts, had 9 docs. And then over the ensuing, 18 to 20 years, we built that to having about 42 contracts and about 260 emergency physicians. So, back in the day when I started in the 80s, about 80% of docs were in private practice. Our contract group was considered a private practice, and only 20% of docs were employed. And you guys know the story with what's happened with that over the course of the last 20 or 25 years. I think now it's the flip. I think that about 80% of docs are employed either by health systems, not-for-profit health systems, which kind of operate in a for-profit manner, or even some public companies and, private equity groups, right? In
Private
fact,
equity, hospitals, insurance companies, now United Healthcare has bought one of the biggest physician groups, and CVS, the pharmacy chains and the PBMs,
right.
are now part of the insurance. They have a wide network of physician and NP offices, right? So we are the minority. There are no more private doctors, and we're a dying breed, which is sad.
Except for you guys. So, but I think it's very difficult to serve so many masters, very difficult to serve the patients and make sure the doctors and the staff are doing well, and then also serve the shareholders. And so I have kind of an old-fashioned but continued belief that the docs that are owners have more stake in their practice and more of an interest in providing a high level of service. So I know you guys have great clinicians on here, researchers, people employed in academic settings, people employed in some of those health systems, and they're all doing great things for patients. But I just kind of believe it's kind of like when you're going out for Italian, maybe not with a lot of pasta, but you're going out for Italian, and you can hit the chain restaurant, or you can hit the mom and pop place down the street that's been a family business for 60 years. And I just think that if you own part of the practice, maybe not individual, but a group practice that's owned by the physicians, I just think you have a tendency to you're more vested in your patients and the service, and provide, a little bit of a higher level of care. So, we're a little bit of a dying breed, but I guess that's, my view on this.
Yeah, I think we're a dying breed, but we're a reviving breed too. I think enough doctors are sitting there going, wait a minute, I'm killing myself here for the system. And if I leave, someone else will just plug in and follow the, whatever the cookie cutter that they do. Here's this condition, here's how you treat it. Like, it's all scripted. It's like having a movie rather than saying, okay, let's write the book right now together. Right. So there's I think a lot of doctors all of us went into medicine to really help people. But then what happens, we get into the system, we start getting chewed up and spit out and beat up. And, you look at our divorce rate, our suicide rate, our alcohol abuse, drug abuse, all these things we're trying to help people with. And obviously you're in addiction medicine, and you see that probably with physicians struggling just because of the demands that are on us.
Right. It's, I don't know how you guys did it, seeing 30, 35 people a day in your office. So, hey, I got a direct primary care story for you. Okay. So I'm not primary care trained, but I was thinking about this when I knew I was going to be on with you guys. So my grandfather, who died before I was born, was a doc in rural Ohio, between Toledo and Dayton, like way out in the middle of nowhere, a little town called Lipsick, Ohio, in Northwest Ohio. And my mom, so he was a doc like in the 30s and early 40s out in up there. And so my mom used to tell me stories about how he used to bring, he would go take care of people and he'd bring home vegetables for payment, and he would bring home pies. And she said, one time he brought home a mechanic to work on the car. So it was kind of a barter system. And she had a vivid memory of him being called out to deliver a baby one night, went and was apparently a difficult delivery, was there all night and showed up the next morning with defeathered chicken in each hand, on the front porch. And, that to me, man, that's direct primary care. So, and that's the way it used to be.
Sounds like your grandfather was a pioneer back then, huh?
Yeah, he was a pioneer, sure enough. So I was going to tell you a little bit. So we grew this group, and what I did for a while was I'd go out and start contracts, a lot of them in rural Ohio. And we'd get the contract up and running, get staffed, and then, would move on to start another contract. So we gradually grew the group that way. And I had a great, experience clinically. Quite honestly, after, almost 30 years, I still enjoy just, pulling back the curtain and sitting down and talking to patients. But and some docs get burned out on that, but I just, it's something special. We are privileged to do what we do. And I'll give you an example of that. Even just a month ago, I still pick up a few shifts at the VA in Dayton here, which I really enjoy because the pace is slower and I have time to sit down and talk with the patients. But I got a healthy guy. He comes in, he never sees his doctor. He's a construction worker, and he says, I got this cough and it won't go away. And then, I'm also getting headaches. So, I'm thinking, here we go with this multiple complaint type patient, and how am I going to cover all this in a single emergency department visit? And so I start working him up, and I get a chest x-ray. And of course, he's got a mass in his chest. So we get the CAT scan and further define that. And I'm thinking, well, he's got headaches too. I better look there. And he has brain metastases. So here's a guy who, goes from being perfectly healthy, very active, and just in this moment, his life has changed. And he doesn't even know that yet. I'm sitting there looking at the CAT scan images and just, feeling so badly for this guy. And then I have to get my thoughts together to go into his room, no family there, and just kind of explain what's going on, with the right approach of sympathy, but being able to explain, what's going on so he understands what's going on, maybe touch on the issue of prognosis without having him lose all hope. And in what other profession can you do that? You're involved in the most important and intimate portions of people's lives. And I still get emotional about it. It's a privilege to be able to do that. And we have a responsibility to do it right. But I just, I'm still touched like that and feel privileged after all these years. And I'm sure you guys have experiences like that as well.
Yeah, I think that's the important part. That's what we all love. Once we close the door, we're there one-on-one with the patient. That's where we get our joy. That's where we love it. Then we leave the patient. Then we argue with the insurance for an hour trying to get meds covered, trying to get the pharmacy saying, hey, look, I just dealt with that recently. And you just think, gosh, darn it, I'm glad I'm out of that system because it's so frustrating. You want the best for your patient, then the treatment they need gets denied. And, just as an example of direct primary care, why I love it, one of my patients here was excited because he has a PPO insurance and to get his MRI, he goes, oh my gosh, because he needs to get a knee replacement. He goes, it's only $900 now. He goes, it used to be like $1,500 with my old insurance. Now it's only $900. I go like, if you want to do cash pay, it's $500. I think it was $450 here in San Diego to get an MRI. He's like, seriously? Like half of what I'm, right? Like his payment is twice what he could pay cash for. It's like, it's insane. So he's like,
Right.
okay, done. He goes and gets his MRI. He's happy. It's like, he goes, I saved another money on top. rather than you. And it's incredible. I have people now with full coverage insurance, and they're like, how much is it for your lab panel you get for like metabolic health? It's usually like $81. You want to get your lipids and your 3-month sugar average, and your, and Tro and I can do finger sticks. And when you start saying, gosh, $81, and my copay for my insurance is $300 when I get the same testing done, and you think, wow, like we could save so much. I mean, because the primary care is not what costs the money, it's the emergency care, right? So yeah, it's really amazing when you see stuff like that. But I think that's an important point, is that, man, we could do a lot of good for a lot of people. Tro, what do you say, man?
No, it's absolutely right. It's just it's a terrible situation with insurance. We've been marking up prices. The labs mark up the prices to mark them back down for insurance companies. And I mean, how much does it cost you, Brian? I mean, it cost me roughly, I don't know, $25 to run, or maybe, I don't know, $40 maximum to run a set of labs in my office, right? And the insurance company's charging like $500 for that same exact test. It's insane.
Yeah.
I mean, sorry, the hospitals and lab groups. It's just a big mess that we're in. It's a big financial mess that we're in. And the bottom line is nobody cares about the person, right? It's not the primary care docs that are here's the flip side, Brian. You had to become a service. You had to find cheap labs. You had to find cheap imaging. You had to use your connections to benefit that person, right? Because they're going to pay out of pocket. They're going to pay $5,000 worth of deductible, right? So we not only have to get people care that they need, we have to get it in a way that they can afford. If you prescribe $1 million drug, they can't afford it, right? What's the point? What's the purpose? Right? This is the problem in modern medicine. I think direct care is a big part of that.
Yeah, and quite honestly, thank God there are people like you guys out there that are educating people and directing them in this manner, because people just don't know. People don't, I can hardly understand a lot of this system. So people don't know that they can get services, better services cheaper through the model that you guys provide. So I think that's
that we
great.
provide now, right?
Yeah.
That we provide. So because I think it's important, and for us, we want people to be like in your area where they can reach out to you and say, look, why come all the way to New York or California? That we have to have good doctors. And that's why we started this podcast, to give a platform to docs like you who say, yeah, I'm doing the same thing. Partially because it helps protect us, because when we have more and more people saying, yes, I'm doing this with success, we're not as nutty as we used to be a year and a half ago when everyone thought we were crazy talking about this stuff, right? Because everyone knew you just give more insulin, and but we see the ramifications of that, of not treating the root cause. So in your case, I'd love to talk a little bit more about what you're doing with addiction, because that's a root cause of a lot of the stuff we're treating. We're talking about cirrhosis and kidney failure and blindness and poorly controlled diabetes. All these things kind of run together sometimes.
Let's talk about that. I'm going to finish the story about the emergency medicine group, but I'm going to give you one more quick anecdote first. So I was working in one of these rural hospitals in north central Ohio, and there was a doc there, old Doc Gray, Grey, and he was a county coroner, and he had been a GP in that area for like 55 years. So, we talk about the privilege of medicine in this day and age and still having the opportunity to take care of people. So he was one of those coroners, one of those docs, even though he had a primary care practice. He would come in, actually you called him when you had a death, and he'd come in to do the death certificate. That was a different day and age 25 years ago. So one night he came in, and what happened, we got to be friends because I was working a lot of night shifts back then, and we sit in the back break room drinking coffee and gabbing. And he came in once, and I distinctly remember this. He had probably started his practice in the early 30s or so. And I asked him, well, you've seen a lot of changes in medicine. What do you think was one of the biggest changes that you've seen? And he said, well, when we got our hands on penicillin, that was a pretty big one. And it was like, and then he went on to talk about how, kids were dying of, routine, strep pneumonia, and, mothers were dying in childbirth from infections And then, you know, in the late 30s, early 40s, they got a hold of penicillin and all that changed. So sometimes we forget how long we've come in such a short period of time. And again, for me, I just feel lucky to live in an age where we can actually, you know, make an impact on people. And, you know, now I'm in an independent practice setting, so I get to enjoy it like you guys enjoy it.
You know, I want to talk a little bit about that. People don't understand that the paradigm completely changed. You know, if you look at things like endocarditis, which is an infection of the heart that affects the valves of the heart, right? When you get bacteria in your blood and it sticks to the heart valve, right? And then it becomes a kind of localized infection in the heart. You know, Osler would describe, the way Osler described this, the grandfather of medicine, he literally would talk about these late manifestations that you'd see from endocarditis, right? You'd see things 1 month in, 2 months in, 3 months in. They literally call them Osler nodes, these painful parts of your finger, right, that hurt when you touch, and these splinter hemorrhages, right, that, you know, you'd see these little kind of black, red marks in the nails, right? You'd have these findings in the eyes, okay, that you'd see this deposition of basically immune complexes in the eyes, right? And you see all of these things, right? People would get strokes, right, later on. And this was like the cancer, you know, of the 1900s, the early 1900s, because these docs would see this happen and they had nothing they could do, right? They literally watched this unfold. First, they'd get, you know, maybe they came in with bad teeth and a source of infection. Maybe they were, you know, I don't know if there was IV drug abusers then, but probably the biggest cause was dentition, right? And the bacteria would seed into the blood and they would get this infection. And a good doc would listen to the heart and hear it. And then over the next 4 or 5 months would see all of these things unfold.
Yeah.
The minute antibiotics came out, it was gone. Right? Have you guys ever seen an Osler node?
I have not.
Yeah, Brian, you've ever seen an
No,
Osler node?
no.
Right? Right?
Yeah.
But we learned about it. And
Yeah.
the reason why we learned about it was it was commonplace. And the minute penicillin came out, it was gone. It was gone. Now we see it with like really aggressive staph infections of you know, in IV drug abusers. We may still see it, but it's rare, and it's crazy how the paradigm can change, you know, in a year's time.
Yeah.
And maybe that's what we're on. Hopefully that's what we're on with therapeutic carb restriction. But it's actually what you're talking about here, Dr. K, is so paramount and so insightful, that a big paradigm change, we have come a long way. You know, and that was probably one of the biggest changes in medicine, right?
Yeah, I'm sure.
I'd say antibiotics were probably one of the hugest you know, impacts on modern medicine.
Yeah. So anyways, I'm going to finish the story about the group. So we grew, we grew this group, and then you know, some of the docs ended up looking at, you know, what could we do, you know, quite honestly, just to use the word frankly, to monetize that effort. Because the private equity groups started coming around, nosing around, you know, suggesting that, you know, they could be involved in the group. And quite honestly, I didn't want to go that direction. So I actually just left the group at that time. And what happens in general, I can't speak specifically to that experience, but what generally happens in that situation, if a group of docs is looking to sell out, as you know, has happened, you know, a lot over the last 15 years or so, you know, as the hospitals and health systems have bought up the group, is that the group then wants to kind of optimize, you know, that transaction. And so what you look at doing, I mean, it's simple math. It's like, you know, I'm going to get paid a multiple, a price to earnings multiple for my practice. So what do I want to do? I want to increase the earnings as best I can, the bottom line, the net profit, and then get the highest multiple I can. So, docs were kind of, put in that situation where they had to make those decisions. And again, when you're getting ready to sell a group, or your master is the private equity group or the public markets, I just think it's really hard. It can be very difficult to have a quality situation in terms of your patient care. So that was kind of the story around that. And about that time, I don't know if you guys remember this, but the insurance companies consolidated first. And so I was seeing this, in the rural markets that I was working. So, you went from having 5 or 6 insurance companies, health insurance companies in a market, to a lot of places now only 2. It might be Anthem and United, or, maybe 3. So it's essentially an oligopoly. And then a few years after that, the docs had to kind of follow suit. So they really couldn't, they had difficulty doing that on their own. So the docs joined, the health systems. And then what happened was, of course, the health systems consolidated to fight back against the insurance companies. So, and I don't know if you guys have experienced this in your market, but, there might have been, 6 or 7 different hospital corporations in a market, but I think in most markets now there's 2 or 3. I live in Dayton. There's only 2 now, and they're not for profit. They both have, over $1 billion endowments, now foundations to help fund their expansion. And, they do a lot of work. They good work. They do take care of people, but that's how, the business of healthcare got big. It was the insurance consolidation, and then the health system consolidation, and the docs, were not as adept. Some markets, there are docs, great multi-specialty, independently owned practices, but in general, that's really what kind of spurred this transition from 80% of docs in private practice to now 80% of docs being employed. Is that what you guys have seen as well, or?
Yeah, absolutely. And obviously what that does is restrains you too, because you see crazy stuff happening in medicine. You can't really speak out about it because you're going to get fired. You work for someone. When you're your own person, people can not like you for saying what you say, but it's not like you're going to lose your career path, right? So that's one of those things. It's really a hard thing. A lot of docs are constrained. We've had docs that can't come on the podcast and talk about what they're doing because they say, well, if people find out I'm doing low carb in this setting, I'll get in trouble. I'll get reprimanded. And so it's a different. So once you go on your own and say, look, here's my results, I'm telling you, it's a mixed blessing and a curse, right? Because there's a huge HMO. I have 160 now of their patients coming to me. They're paying full. They don't care because they're getting paid, and I'm saving them money, right? Because when I ask the patients, why are you paying them full price and then coming to me? Well, I just have them in case I get into a car accident or something major. I have you for like my real medicine. Like when I'm sick, I want to call someone. I don't want to see a different doctor every time I go in. I don't want to sit there for an hour. I got stuff to do. So for $100 a month or whatever it is, it's like, it's worth it for me to be able to call you when I need a prescription done, or if I have a sore throat, I could zoom in with you and get it done today, because it's supply and demand. And I think part of it is we need access to doctors. You need access. It's not about having insurance. It's about having access. It's like, if you have, $1 million in rupees, no one's going to take that. Doesn't matter if they're not taken, or if there's no one available. If there's only one bus and 1,000 people have a free bus pass, only a few people can get on the bus every day. So that's what medicine has become. It's become such a disaster that doctors in the system, they're like, as a matter of fact, at my old practice, a couple of big systems wanted to buy us out. But what happens is once and I talked to doctors who did that before, they sounds great. You don't have to worry about hiring and firing. We'll take care of all that stuff. Oh, by the way, now you're going to be seeing 35 patients a day, and you're going to be doing this, and you're going to be writing reports. And you realize, oh my gosh, you have no life now. Now you're a hostage. Now you become a hostage instead of having your own practice where you can make decisions. And that's what's happened to a lot of docs. And I think that's a big problem in the system, because they have to see more and more patients to make the same amount of money. Right. Because when you have 2 health insurers in town, they say, well, if you don't like it, go somewhere else. Right. Yeah. If you're stuck with the insurance model, you only have one other option. And they both know that. So they both, I'm not going to say collude, but basically they're saying, well, the reimbursement is going to keep going down every year, and you have to do more to get that reimbursement. So you have to keep circling more boxes and adding diagnosis codes and doing all this craziness. And that's where doctors get, that's where I was getting burned out. I said, I don't like this. I want to take care of my patients and not deal with all this political stuff.
Yeah.
And I know
Yeah.
Tro's shaking his head like crazy too, nodding his head, because he knows how it is too.
Yeah. I was in the system, right, where a big hospital tried to take over my referral network and, wanted me to send patients to their, cardiologist. Well, their hospital didn't even have a cath lab, right? So, it's terrible. It's terrible. It's terrible for if we continue to allow hospitals, venture capitalists, insurers, and pharmacies to buy physician practices, we will have no independence as a profession, and you can already see it. Like, our profession's becoming a bunch of lemmings, right? Like, they're literally just doing what insurance companies want us to do, right?
Yeah.
Who wants to?
Because that's how you're rated. You're rated on that. They go, did you do this, and this? Not by like saying, hey, let's try to get the person off their insulin. If you don't have them on insulin, you get in trouble. If you don't do certain things, you get in trouble. But they're not on a statin drug, you get in trouble. If you order too many tests, you get in trouble. But the patient needs the test done. Give me a break. And I have people coming to me because their doctor refuses to order tests for them. I go, order the test if it's helpful, if it's useful, right? But if they don't understand it, they're not going to order it. Like a fasting insulin, good luck. It's crazy.
Yeah.
For a $12.95 test, all right, at my cost. So you start looking at stuff and you think, what the heck is wrong? I mean, what are we doing here at some point? Because really you want your doctor to know who you are, and you want to have that intimate relationship. There's no more intimate relationship than other than a marriage relationship, but a physician-patient relationship is very critical, because the patient, who's going to call every 5 minutes, who's going to, if they call, I have a guy, he called, I'm like, I know you would never call me, so let's get you in, man, because I know you would never come in unless you've got something going on. Turns out he has severe diverticulitis, right? And we got him squared away and he's doing better. So I think it's things like that where you have access. Otherwise, you sit there for a week and try. As a matter of fact, I'll tell you one other, since we're venting a little bit. I remember my biggest frustration, one of them was I would do a referral to a specialist, like a urologist. And I go, oh, can't see you for 9 weeks. 9 weeks, the guy's got a problem right now. So then what happens, the patient complains to the system, and then I get docked because it took too long to get the referral. I'm like, that's the insurance system's problem, not mine. I did the referral the same second. I called you guys 5 times to get it through, and you guys don't have anyone available. That's not my problem. Why am I being docked for that? It's a system problem, not my problem, because I'm doing everything on my end. Once I submit it, you guys got to get that patient into the specialist, hire some more specialists, and then the patient can have a good experience, right? So it's all those kind of things where you start saying, well, gosh, there's certain problems you can't fix. And in the private sector, what we could do is call the guy and go, hey, look, man, I'm referring a lot of patients to you. I'd really like if you get this guy, and he really needs to be seen. And they go, okay, Brian, no problem. What time? Done.
Yeah. That's great. So actually, I learned about this economic principle a few years ago. It was in the context of medicine. This is interesting. There was economists. It relates to how many patients a doc can see. You say, you're seeing 35 people a day, and how do you do a good job doing that? But the principle is named after an economist in New York City by the name of Baumul. I think it's Baumul. Have you guys ever heard this at all?
No.
Okay, it's called Baumul's law, and it talks about how you can only increase the productivity in medical care. A doc walking into the room and working with a patient so much. You can only increase that efficiency to a limited degree. Yeah, you can use scribes and you can use, physician extenders and, computer systems, though I would allege that, the computer systems have slowed me down over the years more than they've necessarily helped at times. But it just, a doc one-on-one with a patient takes a certain amount of time. So this economic principle says that over time, then that kind of labor intensive interaction is going to become less efficient. You can increase, the technology in the field of communications, and you can automate manufacturing processes, but it's still, a doc one-on-one with the patient, and that's going to take a certain amount of input. And so the analogy he used, and I thought this was neat, he goes, in the 1700s, what was the input required to do a waltz, a short waltz, and he would say, or a string quartet is what he said, and it would take, 4 musicians, 4 stringed instruments, and about a half hour. And what is the input required for a live performance today? I mean, it's the same thing. It takes 4 musicians, 4 stringed instruments, and about a half hour. So there are some processes that it's just hard to increase the efficiency on. And I think one of those is the physician-patient interaction. As he put it, you can play the minute waltz in 45 seconds, but it's not exactly the same. And I think that's one thing you guys are able to preserve in direct primary care, is that you can preserve that relationship and taking time with the patient, whereas in these other systems, where you got to see 35 people a day, it's nearly impossible to preserve that relationship. So I thought that was interesting. You guys got any thoughts on that?
Yeah, I think it's, for me, I think when you look at it, it's like, what's my overhead now compared to where it was, right? The more people you have, the more staff you got, medical records, you got all these different people. So when you have a smaller practice, you can adapt to that. So you can have a smaller place. So, I mean, Tro and I have smaller offices. We don't have a huge mansion, with gold entryways, right? They're pretty nice though. We have pretty nice setups because we could design it the way we wanted that worked for us, not saying, okay, just make do with what you got and you got to force people through. So we don't have to have huge waiting rooms. We don't have to have all these things. So we can cut and just like what you're doing, you can cut your overhead down. So you don't have to see 30 more patients a day, 8 extra patients just to pay your fancy overhead. So I think there's things like that we're learning, is like, why do you need to have all this crazy stuff? I mean, we have a fax machine and there's not a lot of stuff we need. We have an EKG, we have a few machines that we use, our labs, stuff that's very efficient. So that's part of the problem, is that we have to, when you have like 10 doctors working in a building, you have to accommodate a lot. You have to have a lot of people, support staff for that. If someone's medical assistant calls in, you're seeing 35 patients, it's a disaster. For me, if I'm seeing 10 or 12 patients a day, I can bring them all back myself and do all that stuff. You could just do it on your own if someone's out, right? So it doesn't cripple the system. So I think those are things that we're seeing. Tro, how about from your perspective, man?
No, I mean, this is the problem. You need to spend time with people, right? And you need to spend time up front, and insurance companies don't want to do that, right? How long is your first visit, Brian?
Hour and a half.
An hour and a half, right?
Yeah, hour and a half, depending on that. Like if we're doing medical weight loss, hour and a half, because we got to get to the bottom and figure out, connect, and it's very important to know where the patient, why they failed, what they've tried before, because we're not going to reinvent the wheel if you failed at what we're trying to do.
Yeah, so that's the problem, is that insurance companies don't want to pay for that. My follow-ups are half an hour. We do meetings with health coaches that aren't paid by insurance companies. And bottom line is, if I think the way the insurance companies want me to think, I'll become a bad doctor. And I'm not doing that. I'm not going to do that, right? And I'm going to do what it takes to serve my patients. And that's the problem in medicine, is that you get out, you're programmed to think the way they want you to think, right? You have to do a bunch of undergraduate work, organic chemistry, biochemistry, physics. Then you go to medical school, you have to learn it all, anatomy, physiology, pharmacology, right? Then you go do your the hospital rotations, and then you go to residency, and then you become chief resident, right? All 3 of us, chief residents, right? And we're just programmed to learn. And then you get out into a system where insurance companies pay you, $18, and so you want to see people in 7 minutes, right? And what happens is we're not programmed to think. We're not programmed to think outside of the box. We're not programmed to think, am I actually helping anybody, right? And that's the problem. And if you step outside of that model for 1 second and think, how do I actually inspire behavior change in the person in front of me? What is it going to take? It's going to take time, resources, help, support, right? Helping them prepare, right? And that is not paid for by insurance companies. That's the problem.
And we know it's upfront cost. It's upfront heaviness. You take a loss at the beginning, because for us, once we get our patients healthy in a good lifestyle and on board, and plus we've selected for people who care about their health because they're willing to pay for that, then they're an easier patient for us, because now we're not adjusting meds, looking for side effects and all this. We're tapering medications, and that's the skill, right? Is figuring out, okay, how do we get you off meds, rather than saying, oh, just those, because it takes 2 minutes to throw, here's a blood pressure medicine, here's a diabetes medicine, here's this medicine, see ya. Everyone loves that medicine, especially if you're the pharmaceutical company, if you're the insurance company, all that. So you start realizing, look, it's our time that matters. It's our time that we can invest in that patient, that we can help them. And some people we can't help, but most of the time, people who say, yeah, let me try what you're talking about, and they do great, they're sold and they get it. And they don't need 2 hours with us every time, because they're like, okay, I'm feeling great. Let's just do our physical and, get my labs done, and they move on and they're happy. Or when they come in for social, just talk. I have people that I'm their social engagement for the week. Some of my seniors who are stuck in a nursing home, right? It's a social thing, and we laugh and we have fun, and that's good medicine by itself. Just making
Yeah.
an 82-year-old laugh and realize life's good, and what are you going to do? How are you doing a bingo, right? Just having interaction, because the worst thing you can do to someone is isolate them and have no interaction. It's
Yeah.
terrible. It's a terrible thing. It's horrible for people. Like, solitary confinement is what everyone fears, because being stuck with yourself is kind of tough, especially if you're Tro. Could you imagine Tro just being stuck with himself all the time? That would be really rough.
Well, so
That's why we let him do the podcast.
how did you segue? How did you segue into addiction medicine?
Okay, so the story there is that I just started seeing too many overdoses in the emergency department, and it got to me. And you have you have the whole spectrum of those. Some of those were the people that got Narcan and they wake up. This is the medicine that is given to people when they overdose, and they wake up and they're mad that they're there, and they storm out of the emergency department to go continue their use. They try and get out the door with their IV in still, so they have ready access when they get home. And then, but I think the tragic cases really are, I had a few cases where it was a young person. I remember one case in particular, a young mother, couple toddlers, boyfriend there, and she didn't die. She just got anoxic brain injury. So she's basically going to be vegetative for the rest of her life. And it was just such a hard situation. So, I started looking at what the options were to treat people. And initially, when we started our practice, it was, primarily Suboxone, which is an opiate alternative. I think you guys are aware of that. It's a medicine that binds to the opiate receptor and doesn't give you the euphoria that fentanyl and heroin do, but it keeps you from getting sick. It keeps you from going into withdrawal. So there were boards available to people with addiction medicine experience. So I went and worked in a clinic for a couple years, got the number of hours needed, then went out and got my addiction medicine boards and opened my own practice. We still treat opiate patients today, but I actually have some PAs that are working with me and another physician that's a partner, and they're doing most of the opiate work now. And I've kind of gravitated into this area that I was hopeful we would have a little time to talk about, which is treatment of alcohol use disorder. So are you guys familiar with the Sinclair Method at all? Have you heard of that previously, or any patients on it?
Yeah, we briefly had somebody in addiction talk about it, but why don't you educate us?
Okay, so the Sinclair Method has taken patients with alcohol use disorder, and there are these criteria for substance use disorder. Does it put you in a harmful situation? Does it take time from things you previously enjoyed doing? Has it affected your relationship? So you go down this list of criteria. But actually, I created an independent criteria, which I ask the patients, which is, are you drinking more alcohol than you want to be drinking? And if the answer to that is yes, then I want to try and help them reduce their alcohol drinking. Now, the Sinclair Method is providing naltrexone, which is a 100% opiate blocker, before you drink alcohol. So it's an intermittent use thing where you take naltrexone an hour before you drink alcohol. And then on days that you are not drinking any alcohol, you don't take it. So what we're doing is we're capping those opiate receptors, muting down your endogenous enkephalins and endorphins, and then downstream to some degree serotonin and dopamine, so that you don't get that warm and fuzzy feeling from alcohol that you would otherwise. And then you try and let those receptors run wild on days you aren't drinking. If you aren't drinking today, then you need to go out and, whatever it is for you that makes you happy, a walk with the dog, getting outside for a while, working out, whatever that is. And then gradually over a period of time, the brain learns to not enjoy alcohol as much. And I had patients that come to me that are drinking. We always measure things in drinks per week. We kind of drill down to drinks per week. That's the parameter we follow. And I have people that come to me that are drinking over 100 drinks per week, and that's out of control, obviously. And I've had people come to me. I had a doc come to me that was drinking 12 drinks per week, which is within the CDC guidelines for alcohol use, but he was on call 3 or 4 days a week, and the other days he was drinking more than he wanted to be drinking, and he wanted to get those numbers down. So I realize this can be viewed as a little controversial in a historical perspective, but I'm going to give you my frank perspective, and that is that I think abstinence is great for people that want abstinence and can do abstinence. As an aside, people that pursue abstinence often have a high relapse rate, which I think you guys are aware of, and then they sometimes get into these cycles of binging and abstinence and binging and abstinence. But I do think there is a place for management in a gray area. In other words, it's not necessarily black and white. It's not necessarily abstinence or non-abstinence. It's decreasing your alcohol use and working with you over a period of time to achieve that. With the use of naltrexone, and then I work with these patients in a behavioralist manner as well. We set goals, at least every month, which is how many alcohol-free days are you going to have in a week? What's the maximum number of drinks you're going to have in any given setting? Maybe we need to try some 1 drink days where, you can prove to yourself you can have 1 drink and then leave it alone. And the numbers are that I've had now over the last 4 years in this is that about 80% of patients see a significant reduction. That reduction is 60% or more. I sent you guys a few graphs on a few patients. I don't know if you had a chance to look at those or not, but basically, we try and get people down into the CDC guidelines range, which is, very unfair to women, but it's, 7 drinks a week for a woman and 15 drinks a week for a guy. And these are people that, we encourage abstinence. For people that are heavy drinkers, we want to put them in the position where they can become abstinent and move on to complete abstinence if that is best for them. But for a lot of people, just to be honest, they want to keep drinking. They want to be able to have limited social drinking, and so what we try and do is put them in that position. You guys have thoughts or comments on that?
Oh yeah, all these things are kind of controversial, right? You tried to look. As a matter of fact, I remember when I was doing trauma at one of the big hospitals, and I opened the fridge on the wards, and they have beer in there. I'm like, what the heck? There's Bud Light in the dang hospital refrigerator. And they go, yeah, that's for the trauma guys. I'm like, trauma guys are drinking. No, for their patients, because some of these patients don't want to quit drinking, and they're here for a week, and we put them on Ativan. We do all this crazy stuff that costs tons of money. They go, they do just as well having a beer a day. If they're not going to quit, why are we going to get them off alcohol and then put them back on alcohol when they go back to the street? So it's cheaper for the hospitals. I was like, oh my gosh, I was like blown away by that. It's pretty amazing when you think about it. But if you're trying to prevent withdrawal, it was working. They would give, they would titrate for how much they were. I don't know if anyone else has ever seen that, but I was surprised by that. But, it's a hard thing because, Tro and I, we've talked a lot about this with abstinence versus not today, maybe tomorrow. I like that mindset. Like, okay, I'm not gonna have pizza today, but maybe tomorrow. Not saying you're never gonna have pizza again in your life, but okay, just not today. I'll put it off till tomorrow. And then, with alcohol, it's such an addiction. And carbs, there's no question. I talked to a lady last night. She's in tears because she knows she's addicted and she doesn't know how to break the cycle. So it's hard, and you tell that person you're never gonna have cookies again, and then they go into a depression, they freak out, and then there's so much in it, and it's one size fits one is what I think, is that you figure out that person. How do we reach that person? How dedicated they're? How bad do they want their goals of coming off alcohol? And Tro, what are your thoughts on that?
No, I think you have to go with the least harm approach.
Yes.
Right? So the least harm. So I had a consult yesterday. I mean, diabetes is not alcoholism, but I had somebody with an A1C of 10. And I'm talking to him and his wife, and I'm saying, look, it's not that these foods are bad, right? It's not that a banana is bad. It's not that bread is bad. It's not that these foods are bad. It's that your body can't tolerate it, right? Your body can't tolerate it, right?
Right now.
And exactly right now. And the same with alcohol. If somebody's alcohol use, I've met people who don't drink alcohol at all. I don't remember my last drink, right? But if I get together with my friends, right, and I have a couple of drinks, and that de-stress, the camaraderie and the de-stress in that social environment, that actually gives me enjoyment and de-stresses me and improves my mental health to be in that kind of environment. Is that a benefit to me? Maybe, right? Now, is it a benefit to me if I drink those 3 drinks and then drink another 3 drinks the next day and then 10 drinks the next day? Probably not, right? So you have to figure out who that person is in front of you. My wife can eat pizza. She can have a half slice of pizza and be like, I'm done. Brian, can you eat a half slice of pizza?
Never have before, man.
Never have, right? So part of this is understanding who you are as a person, if you're the patient, but as a doctor, who's the person in front of me? Are they a moderator? Can they abstain? Can they not abstain? Should I push them to abstain? And ask them, what do you think you can do? It's as simple as that, right? What do you want to do? So we shouldn't push people to things that they can't do or don't want to do, right? If they can do something and they want to do something, well, we'll help them get there, right? So I think that's key. That's why, I agree with the approach, the less harm. If you can get somebody down to 7 drinks a week, from 40 drinks a week, is that good or bad? Right?
Good.
That's good. That's great.
Yeah. And
Yeah.
and if naltrexone helps with alcohol, then that helps. All these things and what we've been impressed with talking to the addiction people is what we were saying before was, okay, if you get your alcohol under control, it's easier. Like, there's a lot of people, they go off the rails because they have a few drinks. Like, okay, screw it, I'm gonna have some cookies tonight. I'm gonna go out and have my and lowers that inhibition to have more alcohol, more make bad decisions on going home with people, all those kind of things, right? Poor decision making. So I think of those things when you say, okay, if I can minimize that as much as possible, then I minimize all the other behaviors that go along with that.
Yeah. So basically, we just want to put people in the position to be successful. I want to encourage people to be abstinent when they can, but some of these patients have tried that before. Then I have people that professionally, like I have a personal financial planner. He's out with clients all the time, and my initial experience with him was he was drinking 50 drinks a week, and now we got him down to drinking 7 drinks a week, and he feels that is manageable long term. And the other thing I'll say is, we don't treat diabetes or heart disease or cancer the same way we did in 1935. Which is really kind of the paradigm for alcohol treatment now. It's abstinence and an AA approach. And I'm not against that. I think that is great for the people that can pursue that. And I have patients that I've worked with over a period of time, and they can't control their alcohol use. And I say, you need to go be abstinent. So you need to go to AA or Smart Recovery or get the support that you need to be abstinent. But I do think, we should use the resources that are available, and in this case, naltrexone and the Sinclair method to achieve that end. And I'll tell you, the one thing that does bother me a little bit is that this approach is very common in Europe and in Asia. In fact, I had a patient that was a doctor, and his wife is Japanese, and he was kind of embarking on this. This is the guy that didn't drink very much because he was on call frequently, but he just wanted to get his drinking down further. And his wife, looked in, on the internet in Japanese, and she goes, "Oh yeah, man, they do that. They've been doing that over there for years in terms of this approach." And then the flip side of that is, I think that this approach has not been promulgated in the US because people in power or people with financial interests don't want it to be promulgated. I mean, why would you want to work with a doc one-on-one in an office once every couple weeks? You know, actually, you should want to work in an office-based setting where you're there in your current stress environment with your family or your job or whatever, as opposed to going to Malibu, you know, and spending $30,000 for 6 weeks and then getting kicked out back into your environment and relapse. So I think the rehab industry, to a great degree, hasn't, you know, is basically blocked this approach in the US, because it's a great business model to have somebody go into rehab and then fall off the wagon and go back into rehab for another stint. And 90% of alcoholics, you know, actually use the term alcohol use disorder now. 90% of those people do relapse within a 3 or 4 year period of time. So again, I think this is something that we need to consider for patients. And if it helps with their decreased carb use as well, then, you know, more power to them.
Can I talk about this for a little bit? I want to talk
Sure.
about something that, you know, you're an emergency room doctor, and I think you'll appreciate this. You know, I've worked in the same hospital system for 10 years, and I just recently left. It's the Yale New Haven Health System. I worked predominantly in Greenwich Hospital. Did my training there. It's a Yale internal medicine program. And basically, the 10 years I was there, I had one patient that I have admitted to the hospital probably over 50 times myself, okay, in those 10 years. In fact, this patient was probably admitted over 150 to 200 times. Every single emergency room physician knew who he was. Every single hospitalist in that institution knew who he was. Every single resident, every single nurse, right? Probably he is 500 people have touched this patient, right? He recently passed away, and it really left emotional impact on me. And he had a severe alcohol problem, and all of his medical issues were related to alcohol. He was an alcoholic, alcohol abuse. He was depressed. He was disenfranchised, poor. And before he died, maybe about a month before, I sat down with him on another one of my missions. And I said, enough is enough. And I'm going to sit down and just talk to this guy. And I want to understand what is going on in his life. And he looked at me, and I remember this very clearly. He said to me, I don't want to drink. I've never wanted to drink. It actually feels bad. It feels bad, right? And he went on to tell me about his power, money issues, the abuse he's gotten from the local police and the, other, passerbys. He's poor. He's on the streets. Basically, he's, abused by people on the streets. Kids beat him up. The police, they're so tired of dealing with him. They were so disenfranchised, right? He just would kind of get bullied by them as well. And he would come to the emergency room, and even the emergency room, every single staff member would say, oh, he's back again. Mm-hmm. That's the response. Oh, he's back. Oh, he can't be helped. Okay? 500 healthcare workers who were all, supposedly inspired to help people. 500 people couldn't help him, right? They would say, and when he passed away, when he died, people said, wow, he's in a better place. He was suffering. These people would never give him time. Nobody gave him time, right? Nobody spent the time with him. And 500 people who think that they are inspired, you know how much money that costs to take care of him? 500 people have evaluated him multiple times. The doctor's visits, the emergency room visits. The cost to the hospital system was probably in the millions. We could have literally given him millions of dollars, taken him off the streets, right? Put him in a Malibu program, put him in the Sinclair Method. If somebody cared, if somebody could have done better, right? And instead, what do? His whole life was, oh, he's back again. Nobody addressed mental health.
True. That's a multifaceted problem, right? First of all, the patient has to want to have help because you can sit there for 30 hours with the guy. If you can't help him, you can't help him, right? We know that from our clinics. So that's a hard thing.
Hold on. I'm
wait,
sorry.
wait, let me finish the thought, and then
wait. You can't think like that.
No.
You went to school to help people. You can't.
Let me finish the thought, Tro, and then we'll get back to this. Because what I'm saying is the poor ER physician sitting there going, look, I got 80 people I got to see today, and I got all this. I'm not going to sit for 2 hours with this guy. The social worker says, look, this guy's not rehab. And so what happens, it's a hard thing. It's just like anything. It's a hard thing because we only have so much time, and you try to invest and you try to get that person. So it's partially the patient's issue, partially the system. What I'm saying it's both sides are a problem, because you know as well as I do, if I have a patient who's committed and they're all in, it doesn't take much of my time. They're doing this thing. And it's hard because when you're dealing with addiction, it's such a huge problem. And trust me, that's why with this COVID thing, it's really the lockdowns, the depression, the anxiety, the stress, the alcohol abuse, all these things we're seeing. Us docs on the front line see the ramifications that are coming from this, right? There's ramifications of this.
Everybody said he's not my responsibility.
I know that's the problem. I agree with you on that.
Beat him up. The police that roughed him around. The ER doctors who said, I don't really, oh, he's back again. I can't help him. The nurses who said, oh, he's back. I'll have to see him again. It's the same thing. That's
a problem for sure. I agree.
A system of disenfranchisement. And the end result is millions of dollars are spent on it, right? So how can we not look at this and say, this is wrong? It's wrong. And you know what? You're right. We can't help somebody who doesn't want to be helped. You're right. But we can't say that because then we are part of the problem. How do we fix that? I mean, we have to be able to Monday night quarterback and say, this whole system was wrong. And I think that's what Dr. Paul is alluding to here, right? Is that, there's so many systems that, look at how many people benefited. The nurses got paid for their time. The doctors got paid for their visits. The hospital got paid for their admissions. The police got paid. The kids that robbed him and beat him up got paid. Everybody got paid, right? But who got helped? Everybody else. Who didn't get helped? The person that couldn't help himself, right? And what is our moral character? How is it? What does it say about our moral character if we can't help these people? Like you and I know, Brian, you've been inspired. You inspire me, man. You inspire me. And Dr. Paul, you inspire me. And if we can't help these people, what are we doing?
It's a hard thing, Pro, because I totally agree with you in spirit, totally agree with you on that. What I'm saying is if I can help 30 people over here or one person over here, I have to help the 30 that want help. And if someone doesn't want help, I could invest, as well as I do. I had a conversation last night. I go, look, until you're ready to help yourself, I can give you all the knowledge, wisdom, all that. If you can't pass up the cookie in front of you, all that knowledge, wisdom, love, peace, patience, prayer, whatever it is, doesn't help you. You have to be able to invest, and you have to be able to, and some people are, and I'm just telling you, that's the reality. And it's like some people, it's a hard thing. If you can't get someone to the gym, you go, okay, you got to work out. You want to run a marathon, you got to train. If you can't get you to train, I can't get you to run a marathon, even if I'm the best marathon runner in the world. It's a systemic problem. But the problem, as you're pointing out, Tro, is that when everyone's rushed and stressed and busy and they're not going to invest. And when you have a stressed out doctor who's burned out and they don't care about their job anymore, do you want them to help someone who's homeless? Like, ain't going to happen. That's the problem. You need these docs who say, hey, I'm helping you. I'm invested. I'm going to help you. I'm here for you. If you need help, let's do this thing. But it's a hard thing.
You want to know what one of the doctors said to me that really got to me, Brian? Oh, this is going to be easy. I can just copy my note. I can just copy my last note.
Yeah, it's a hard thing, man. You lose your compassion.
So at that point,
Paul will know better than us being an ER doc. It's a hard thing when you have these frequent flyers. It's a tough one.
Yeah, I got to tell you, well, first of all, to Tro's point.
Well, he's seen both the people. Actually, tell me about this. How should I view it? Because the ER, you guys see alcoholics and drunks and intoxication all the time. Right?
Yeah.
As an ER doctor, and especially in the VA, just people who are ravished by mental health and PTSD. Right. But what about the addiction side? How do you reconcile the fact that you're bombarded with alcohol intoxication, but then knowing that you can help these people?
Yeah, I think it's about the incentives, as you just indicated. If everybody's getting paid with the system the way it is, then that system is going to continue. So, we could have taken a little piece of that money that was involved in the care of that guy and put it into some type of alternative program where, and again, I'm a proponent of, rather than detox and repeating that cycle, a approach of gradually trying to reduce their alcohol use. But it's basically all about how the incentives are aligned. I mean, that's the healthcare system. The incentives are aligned for people to do well and make money. And if you create an alternative world, which quite honestly you guys have, then you can make headway with your direct primary care and what you're doing with the low carb approach. You can make headway. I got to tell you, Tro and Brian, when you're picking a specialty to go into in medical school, you have no idea what you're doing. You have no idea, if you're really going to be good at being a surgeon or, an internist or an emergency doctor. But I'm going to tell you, I kind of picked the right field, and then it evolved into addiction medicine because, give me a prominent businessman or a politician to take care of the emergency department, and I tighten up and I'm stiff and I'm not comfortable, but give me that alcoholic or the guy that, has got an abscess in his left arm from IV drug abuse. And quite honestly, those are my peeps. I just communicate well with them, and I'm just more comfortable and fulfilled by doing that. And can I change the course of those people's lives all the time? No, but once in a while, it's like the guy who stepped outside his beach cottage, and the beach was covered with all these starfish that had washed up on shore and were gonna die. And he sees this little boy picking up one and throwing it back in the water, and then picking up another one and throwing it back in the water. And he walks up to the little boy, and it says, there's all these starfish here. They're all on the beach. They're all gonna die. What are you doing? It doesn't really matter. And the little boy says to him, well, it matters to this one. And he throws it back in. And that's what this is all about, I think, helping a person, one person at a time, while at the same time doing what you guys are doing, trying to change the system a bit to align the incentives that actually will help people. Go ahead.
No,
Yeah, it's totally
no,
true, man.
absolutely, absolutely. I think, we're coming towards the end of this hour here. And certainly we have some questions. But Brian, anything, last minute we should touch on before we go to the
For sure, I want Paul to give his contact information for people who are struggling with addiction. And I know you're a low carb guy too. Like what's your, how do people get in touch with you if they want help in your area? And are you doing telemedicine? What are you doing so people can reach out and get help if they need it? Because this is right now, it's a critical time for what you're doing.
Yeah, both for diet and alcohol. I mean, it's like,
yeah,
this is it,
Well, thanks. First of all, I didn't talk much about our metabolic practice, but basically we're doing what you guys are doing. You've been doing it longer than me, and I'm admittedly still growing the practice, but we're helping people reduce their carb intake and lose weight and improve their metabolic health. We're doing, CGMs and, having people using their Keto Mojo or BioSense breathalyzer and sending us data and monitoring their remote scales. So it's really kind of bread and butter. There are a few more, I think, obese people out here in the Midwest than there probably are on the coast. And quite honestly, the metabolic health thing is not come as far here in the Midwest. And so we're getting just really busy taking care of these people as we put ourselves out as, the metabolic practice really in this area. And to some extent, I know there are a handful of other practices, but in the Midwest. So our practice for both addiction medicine and metabolic health is in Ohio and Indiana. We actually see a number of people from adjacent states. We have them come to the office once, and then it's a telehealth thing. I would say maybe 80% of our visits now are telehealth in nature, but we'll see people from Western Pennsylvania and Southern Michigan, and quite honestly, especially the Chicago metropolitan area that come to our Indiana office for a while. We're making progress both with our metabolic health practice and then also with the addiction medicine practice. And most of my colleagues are continuing to see the opiate patients, but I'm seeing a lot of the alcohol patients. And there is a little bit of an overlap there. Sometimes we have alcohol patients that realize that they need to address their health in a more comprehensive manner. And then we certainly have our metabolic patients that we can help with their alcohol use. So we can be reached at really two websites. The metabolic health practice is metabolicmds.com. So it's metabolicmds.com. And then our Sinclair Method website is tsmdoctor.com. So tsmdoctor.com. And we've got, email addresses and phone numbers on those websites so people can get in touch with us. And I'm gonna put a word out for my staff. I got the best staff in the world. You guys might argue with that. Okay, I understand that, but I just have a wonderful staff, and people that contact us are taken care of.
That's awesome, man. That's really, really important. So good stuff. Troy, we have a couple of questions.
Yeah, let's do just a couple of them, in this next 2 minutes or so. So do you recommend, I want to say this. There was a study by Volkow from the NIH showing that ketogenic diets reduce the need for withdrawal medications and decrease the desire for alcohol. So that's something but I'm guessing you're very highly supportive of low carb diets in alcoholic patients.
Absolutely. I mean, there's no question from the literature I've read that ketosis reduces alcohol withdrawal symptoms. That's 100%. I'm a little bit mixed, quite honestly, on the issue of, whether ketosis, whether ketosis lowers alcohol use. I don't know if that's because people are drinking less alcohol to decrease their carb use, or really what came first there, the chicken of the egg or the egg. But, if people got those combined goals, it works.
Yeah, absolutely.
Yeah, and we've seen both clinically, and we talked about that episode 13, episode number 10. We even talked about that with these cross addictions. And so we see people doing low carb and they go, "Oh, I stopped drinking." Really?
You know what?
It's crazy.
Can you comment on that about the cross addiction between food, drug, alcohol, and any quick insights you have on that?
Yeah, just that I think it's a matter of setting people up for success. And I think a lot of that has to do with how you monitor them and how you support them. So, I think naltrexone's a key piece of this. Now I haven't used Contrave at all. Naltrexone is one of the medicines in Contrave to help, reduce weight. But I think it's a matter of assisting people in setting goals, whether that be how many drinks are you going to have today or how many carbs are you going to have today, and then assisting them in that process.
Yeah, absolutely. I couldn't agree more. This has been awesome. We got to do this again. We got to keep in touch. I want to keep, seeing what happens to your practice as it continues to grow. This has been absolutely fantastic. We got one last question here. Ron, help finding a doctor who used naltrexone. That's why we're getting licensed in 50 states, brother, because people are calling us asking for help getting CACs, help getting naltrexone, help getting insulin tests, help getting CGMs, and it's just this is unacceptable. And I'm talking to two people here. Hopefully, we can get our brains together and get our heads together and work together somehow to make it so that people can get care across the United States. So that's
the only thing I'd comment on that, Tro, is
Yeah.
make sure you're working with a doc that really understands this process. You know, I've had a number of patients that have gone to docs and asked, you know, their primary care doc who doesn't know anything about it to give them naltrexone. And it's not, I mean, those are great doctors, but they don't know how to manage Sinclair Method patients. And so, you know, sometimes they say, no, I don't want to do that. And sometimes they prescribe it. But if you don't have the system in place, just like you guys have your systems in place to help patients, you really got to have a system in place to help people along with goal setting and, you know, the staff checking in and monitoring them. So, you know, I think in particular, the Sinclair Method with naltrexone is a great thing. And I think getting a script to get that started, but I would very much encourage people to work with a knowledgeable provider.
Absolutely, 100% agree. It needs to be, you know, it's kind of like a CGM. It's great information, but if you can't interpret it, you know, and you can't get actionable insight, right, from that information, what's the point, right?
Yeah, you need someone to interpret it and help and the guidance and the support. That's a huge thing. If you're trying to quit a substance, it's hard to do on your own because you're going to have poor judgment. So having an expert who's walked through this and understands it, that's key. It's really, really important.
Yeah.
Guys,
Hey, I want to go ahead, Tro. I'm sorry.
no. I was going to say this has been absolutely a pleasure. But go ahead. We'll let you.
No, I just wanted to,
to
I just wanted to thank you guys. You know, am you know, new into this in terms of the metabolic health in comparison to you guys. I've actually been, you know, doing it in one, you know, way, shape, or manner probably for 2.5 to 3 years. But I always learn so much by listening to you guys, and I've learned so much listening to your past your past podcasts, which I will continue to do. And it's just is again, when we started this podcast, I'm just honored to be here, you know, and honored to have a relationship with you guys because you are, you know, great models for me to follow.
I'm following you guys.
Yeah, I know we're all following each other. That's what's good. We
Yeah.
all learn from each other. That's
I'm
what
following
it's
you guys,
about.
you know?
Yeah, we have so many people that have helped us along the way, and we love to pay it forward. So it's awesome, you know. And we're going to call you to say, hey, what the heck do we do with this patient? You know. So I think it's great as we get more docs who get it, people who understand, you know, how to help people, and say, look, this is what's working for me. Okay, let's all adopt that and see how it goes, right? So I think there's so much of that we're doing that's fun. It makes it, you know, that we're all here to help people ultimately, and that's how we, you know, iron sharpens iron. You know, I think it's really important. So.
And we're
Troy,
having a good time doing it,
and having a
right?
fun time doing it and not being
Yeah,
totally stressed out and hating the world. Yeah, that there's definitely a bonus to that.
right.
Guys, thank you so much. Patreon supporters, thank you so much. These two docs who inspire me. Brian, you've been an inspiration of mine and a great mentor. Dr. Paul, we've talked several times, and you've been very helpful and insightful. So really appreciate both of you guys. And all you Patreon supporters, we appreciate every single one of you. You make this happen. You keep us not for profit, okay, which we are happy to do.
Thank you, guys.
Yeah, thank you. But thank you, Tro. And obviously, you know, you've been my mentor too. So it goes both ways. Greatly appreciate you, man.